Okay, here's the OBGYN Part 1 lecture, Drugs Used in Reproductive Endocrinology. I'm sorry I couldn't record it today in lecture because the mic wasn't working. So here we go. This is the full thing. Lots of notes, but I'll try to make sure you get everything in a concise message. So first, we have some medications that can act on the uterus, drugs that can cause contraction, and drugs that can cause relaxation of the uterus. First is Oxytocin. Generic brand name is Pitocin, Pitocin, which you hear referred to that a lot in the hospital and stuff. People just call it Pitocin. It's also known as the cuddle hormone, the love hormone. So it's a neuropeptide, and it's just kind of some background for pathophys. You can read through that. It has a facilitatory role in parturition, which is childbirth. It also helps with the milk ejection reflex, so that helps too after the mother gives birth to the child, to help with that milk letdown. And then it's involved in several behaviors, so mating, so it's released during orgasm, parental-child, social, so social recognition can release it, an emotional bond between the mother and child. So right after birth, the oxytocin is released to help that mother-child bonding. It's also found to have protective role against stress-related diseases. So it helps modulate inflammation and helps increase wound healing, or helps decrease the time for a wound to heal. So and it also helps decrease anxiety. Specifically for OB/GYN, it will stimulate the contraction of the uterine muscles, and then it stimulates smooth muscles of the mammary glands for milk production. There are some boxed warnings, and I'm going to add them here. But the first one is for quote-unquote appropriate use, and that is because it's not indicated for elective induction of labor, and elective is defined as no medical indication for induction. And so that's because of it can be dangerous and adverse effects, etc., which we'll talk about in a little bit. But it is so should not be used if there is not a medical indication for induction. You still see it being prescribed a lot and to induce labor, but again, there has to be a medical indication. So, for example, gestational diabetes is a popular medical indication, preeclampsia, or if the baby is at or near term. So it is also note that it is considered a high alert medication, and the reason why is because there's a heightened risk of causing significant patient harm when it's used in error. So it needs to make sure that you have an appropriate use and you're using it properly and under medical supervision, etc. So like we talked about before, it's used antepartum for induction of labor, usually with IV infusion, and again with a medical indication. So not just because like I'm going on vacation or like want to go golf or whatever. And then it's sometimes used postpartum, so to help control postpartum hemorrhage. It can also prevent bleeding post D&C procedure, and help treatment of incomplete, inevitable, or elective abortion. And then I mentioned too the stimulate milk letdown reflex, specifically intranasal. This is more of a historical reference. So in 1995, Novartis, as a drug company, actually removed they had an intranasal oxytocin spray that they removed from the market in 95. So it's no longer available from a drug company. Some compounding pharmacies will still make this, and then they have over-the-counter quote-unquote natural supplement. But part of the reason they pulled it from the market was because of safety concerns, but the other part was that there just wasn't a lot of evidence showing that it was effective, or that it was more effective than a mother not taking it. So just be careful with the over-the-counter natural supplements, and then if you are going to prescribe it, or if a patient really does want it, then probably you have to go with the compounding pharmacy. So it's a specialty pharmacy thing. Adverse effects. So this is part of the reason why you need to make sure you're using it properly, etc. The fetus or neonate can have arrhythmias, and they can also have bradycardia, retinal damage caused by hemorrhage, fetal death, which can be really serious, and related to that, you can have permanent brain or CNS damage. So that's another one that you can have. And then one that's not listed on here too is seizures. So you can add that one on there. This is for the fetus. And then for the mother, you can also have adverse effects. Uterine rupture. You can actually have postpartum hemorrhage too. I know it's one of the uses, but it can also sometimes make the hemorrhage actually worse, even though it's sometimes given to help control it. It can cause uterine spasms, arrhythmia, hypertension that can result in death. So I'll put a little death face. Bleh. Also nausea, vomiting, convulsions, coma, and then there's also death associated with slow oxytocin infusion over 24 hours and with larger doses. So if it is given, you typically don't want to do it over 24-hour infusion, and you want to be more conservative with your dosages. So some contraindications: fetal distress, prematurity. Anytime vaginal delivery is contraindicated. So for example, with abnormal fetal presentation or cephalopelvic disproportion, which is it's a rare disease, but this is where basically the baby's head is too big. Invasive cervical cancer, active genital herpes. And the reason was because this active genital herpes contraindicates vaginal delivery, so this one's kind of related to this one here. Prolapse of the cord, and then on top of that, anytime an OB emergency where surgical intervention is favored. So anytime surgery is favored by the OB-GYN, then you shouldn't be using oxytocin. Alright, so now we're at the prostaglandins. So these first two, dinoprostone and carboprost, you can lump together in the sense that these are both pregnancy category C. And then misoprostol here, this is a pregnancy category X. And the brand name of that is Cytotec. Sometimes people refer to it as Cytotec. Mechanisms of action: they are potent stimulators of uterine contractions, and prostaglandins play an important role in cervical ripening. So we have some uses here. So induction of abortion. So, and of these, this is the most popular one for abortion, the misoprostol. And the misoprostol is typically given in combination with mifepristone or methotrexate. And with these first two, like I said, they're a little bit different. These are used for refractory postpartum uterine hemorrhage. They are the last line. So this is after oxytocin fails, uterine massage fails, and IM ergot preparations fail. They could be used too for softening of the cervix, aka cervical ripening, before induction of labor, and then facilitation of delivery of intrauterine fetus. Fetus, not feces, sorry. Fetus. That's bad. Adverse effects, so prolonged vaginal bleeding, severe uterine cramps, GI issues, GI distress, more specifically diarrhea, nausea, vomiting, constipation. And then carboprost is contraindicated in asthma because it causes bronchoconstrictions. With all three of these, 1, 2, 3, they all have the boxed warning of appropriate use with experienced physician in a facility with immediate intensive care and acute surgical facilities. So these should only be used, by specialist in a proper facility. On top of that, so that's for all three of them, but then specifically for the misoprostone, which is this third one, misoprostol, the Cytotec. So specifically for Cytotec misoprostol, it has another box warning. And like I said, this kind of makes sense when I told you what it's used for, but it has a box warning for abortion, birth defects, premature birth, and so you're not supposed to use the misoprostol for NSAID-induced ulcers unless there's a high risk of complications, and you have to confirm a negative pregnancy test, and then the female patient has to also be on contraception if it's going to be used. So I don't know if you guys remember from the GI lectures, but this misoprostol was in the GI lectures about how it can help with ulcers. Excuse me. So the misoprostol can be used for NSAID-induced ulcers, but it has to be, it's not usually first line. It needs to be for high risk of complications, and if it's a female patient, they need to have a negative pregnancy test, and then while they're on it, they need to have be on contraceptives. So next we have the ergot alkaloids and related compounds. So ergot was originally developed from a fungus, and that can affect crops and stuff. So in the Middle Ages, it would give people problems, and you'll hear about poisoning from ergot affecting their crops. But we have this first one, ergonovine. This one in the US does not have any approved uses for OB/GYN uses, but it does have off-label uses. And then we have the methergine, which is methyl ergonovine, which is brand name methergine. And the mechanism of action for both of those is they increase motor activity of the uterus, and the results in forceful, prolonged contractions. So historically, these were used a lot more, not used so much nowadays, but they can be used to treat postpartum bleeding, hemorrhage after miscarriage, and then hemorrhage after a D&C procedure. Lots of adverse effects, messy drugs, lots of things to be worried about here. I'll let you read through the list. And then the contraindications: hypertension, toxemia, and then pregnancy. It's actually a pregnancy category X. So absolute contraindication for pregnancy. And so because of that pregnancy category, the placenta should be delivered, and you have to rule out the possibility of a twin. And then another one you can add down here related to pregnancy, just go ahead and put breastfeeding. I don't even know why I'm trying to write this. Fast forward through this. Breastfeeding. So the breastfeeding is contraindicated if more than one dose of an ergot alkaloid is given. So it has to be greater than or less than one dose. I don't even know what I'm probably reading. I'm sorry, guys. So now we have some other drugs that affect the uterus. NSAIDs, nonsteroidal. Sorry, skipped it. Nonsteroidal anti-inflammatory drugs. There's a little S. NSAIDs. We're going to talk about this a lot more during the musculoskeletal. There's a whole big presentation on these, but just for completeness sake, they're here with the OB/GYN stuff. And these, in a nutshell, inhibit prostaglandin synthesis and has a lot of different effects, anti-inflammatory, etc. But specifically for OB/GYN, it helps relieve the cramps associated with menstruation, so it helps treat dysmenorrhea. Blocks the endometrial synthesis of prostaglandins during menstruation. They are contraindicated in late second and all of third trimester because they close the ductus arteriosum, which is necessary for fetal circulation. They also can have other fetal complications. In particular, they can cause pulmonary hypertension in the fetus. So, and let me see something real quick. Yeah, and so I'm not going to add more to this. There's a whole presentation on NSAIDs, so just know there is more to the NSAID story. You will see more coming on, like black box warnings, etc. What the? Okay, sorry about that. That just popped up. I don't know why that happened. But you will see box warnings and more information. But you guys will be tested over that, and we'll go over more of that in the musculoskeletal. Beta blockers, beta 2 adrenoceptor agonist. So you guys remember these from the pulmonary module last semester, but terbutaline is actually used. It's mainly used for asthma, but off-label use, it does have some OB/GYN applications, and then ritodrine. These both are basically beta agonists, and you can read through the mechanism of action. They can be used to prevention of premature labor, but that is controversial. And they help relax hyperstimulated uterus, and then relax uterus for external version breech, which is the turning of the fetus. There is a box warning here that you need to note, that they are not approved and should not be used for prolonged tocolysis greater than 48 to 72 hours. So if it's going to be used as a tocolytic, it should not be used for the prolonged use, so greater than 48 to 72 hours. And it should not be used in an outpatient setting. And this is because there's adverse effects like arrhythmias, increased heart rate, hyperglycemia, hypokalemia, MI, pulmonary edema, and the heart rate in the fetus can also be increased, and then they can also cause hypoglycemia in the fetus. There's a lot of reasons why there's that boxed warning there for these. Magnesium sulfate. You guys may be familiar with them by another name, Epsom salt, EPSOM salt, which is over the counter. People use as a soaking aid. They'll soak their feet in it or soak their hand or whatever for minor cuts, bruises, aches, and pains. And so it seems like with the older generation, like my grandparents' generation, they're more likely to grab the Epsom salts. They're used for a lot of other things too, so that's the over-the-counter Epsom salt, but used for a lot of different things. So they are a tocolytic agent, so they can help prevent premature labor. Also can help prevent and treat seizures for severe preeclampsia and eclampsia. They can help prevent hypomagnesia, treatment of pediatric acute nephritis, can help with torsades de pointes. This is an off-label use to help treat that. Treat cardiac arrhythmias, and then short-term treatment of constipation. So they have an over-the-counter product there. Sometimes too, you guys remember from POEM, it can be used for asthma, for acute severe exacerbations. It is an off-label use, but that can sometimes you see it for asthma too, but not first line and for that acute severe exacerbation. Adverse effects, all related to magnesium toxicity, and they all are dose related. So basically, the higher the dose of magnesium sulfate, the more likely to have magnesium toxicity. And they are also a high alert, quote unquote, high alert medication because of harm, the harm that they can cause when they're used in error. So definitely remember this. You'll see this again in toxicity. So they are reversed with calcium gluconate. That's the antidote for the toxicity. But the adverse effects are all these. You can read through all these. Also note that they are contraindicated. Magnesium sulfate is contraindicated in a person who has heart block or myocardial damage. And then it's also contraindicated the IV use for preeclampsia or eclampsia during 2 hours prior to delivery. So you notice back here, I put on here about the preeclampsia, eclampsia. So it's contraindicated if it's used 2 hours prior to delivery. Nifedipine, just generic for Procardia as a brand name. You guys will remember these as a calcium channel blocker antagonist, CCB. But specifically for OB-GYNs, we talked about this during the cardiology module, but specifically for OB-GYN, it relaxes smooth muscles of the uterus, so this can help prevent preterm labor. It's an off-label use, but you still sometimes see it. It can also help with hypertensive emergency in pregnancy, and then all the other cardiovascular uses we talked about before. Here are the adverse effects, which are a review we've been over before, but flushing, headache, common adverse effects that you have to worry about. And then we have contraindications here. Read through those. But this is an interesting note. Don't use magnesium sulfate because it masks the toxicity of magnesium. So you don't know if you won't be able to see the signs and symptoms of the magnesium toxicity, which are all here. So here is an overview of the drugs, clinical applications, adverse effects, contraindications. You'll notice here I want you guys to know the difference between fetus and mother as far as for oxytocin adverse effects, so pay attention to those. So now we're going to get into the hormones, gonadal hormones and inhibitors. Estrogens. So just overview from pathophys. Just look through this. Don't stress too much about memorizing it, but read through it. And we have the female axis and what's happening with their hormones. And we have the hormones during a menstrual cycle. So you can see we have LH, FSH, and estrogen-progestin. And this is endogenous. We'll see exogenous use later. So here we have the kinetics. Don't stress too much about it. It won't. Just read through these, but don't worry about that too much for my testing purposes. Uses, these are important, and we'll be talking about these a lot. But we have all the uses here. So oral contraceptive is the popular one. You guys will probably be prescribing these for. So these are oral contraceptive products, OCPs, or combined oral contraceptive products. We also have estrogen replacement therapy, ERT, or you'll see it written HRT, hormonal replacement therapy. For those different uses. Osteoporosis, we already talked about a little bit. Treatment of vulvar and vaginal atrophy. And then in postmenopausal women, it can help with some of their issues that they have, urgency dysuria. And then suppression of ovulation during dysmenorrhea or excessive ovarian androgen secretion. Adverse effects. So big laundry list here, but I'll let you guys read through these. But the nausea here is a common one. So nausea, stomach upset, abdominal pain is a common one you get a lot of complaints about. That one, and then headaches too is another common one that you get a lot of complaints about. But read through all of these. This is put a star by this was sort of the rare but serious. The DVT, deep vein thrombosis or thromboembolism, PE, pulmonary embolism maybe. But this can be a problem. The clot formation with these is something that rare but serious adverse effect. Contraindications. This first one, first couple makes sense because if there's estrogen-dependent cancer or known or suspected carcinoma of breast, then they shouldn't be giving exogenous estrogen. The liver disease, if you remember back from the kinetics, they are metabolized via the liver, and so it's contraindicated with a person with a liver disease. A history of thromboembolic disorders, so because of the potential for clot formation. Smoking is another one. Smoking tobacco. Pregnancy, and I'll go to the pregnancy categories here in a little bit, but pregnancy, undiagnosed abnormal vaginal bleeding, and then porphyria, which is a rare genetic disease that estrogen can exacerbate. So boxed warning, put a star there. So this is from there was a Women's Health Initiative, WHI study, and where they found that there was an increased risk of dementia in postmenopausal women because of these medications. So you need to think about that, or that's something to remember. And then what else? Yeah, and then this is important here. So because of the contraindications and the box warnings, etc., so estrogens with or without progestin should be used for the shortest duration possible at the lowest effective dose, consistent with treatment goals. So that's something to keep in mind. The other one you can add here to the box warning is cigarette smoking, so tobacco smoking. It increases the risk of serious cardiovascular events, and that risk is increased with age. So it's more problematic with women that are greater than 35 years and who smoke. And then also you can add, so that's one to add that you guys keeping along at counting at home. The other one to add is the breast cancer. So there is an increased risk of invasive breast cancer. It's another box warning you can add. I thought about all I'd read, and I said to myself, either quit or smoke true. I like this ad. This is an ad from the 70s, but I just thought it was kind of funny. You don't have to laugh. It's okay. But this reminds me of the box warning, the one I mentioned. So this is related to the box warning, helps remember. So cigarette smoking, box warning with estrogen, and then especially if they're greater than 35 years old. But this ad's from the 70s before we knew about all this stuff. Selective estrogen receptor modulators, SERMS, aka SERMS. You get this SERM. So these are agonists in some tissues, antagonists in others, and they are therefore partial agonists. First one we have is Clomiphene. It blocks estrogen via negative feedback loop, increasing FSH and LH. So this has helped in infertility, and it has a longer duration of action than estrogen. And its adverse effects, pretty common: ovarian enlargement, up to 14% of the population. Multiple pregnancies. This is where sometimes women, after their own fertility medications, will have more than one baby at a time. Hot flashes. The other one to add on here is GI upset, GI discomfort. And then the other one to add up here, rare but serious adverse effects, are ectopic pregnancies. So it's less than 1%, but it's one of those rare but serious adverse effects. Tamoxifen and toremifene. So these, as far as mechanism of action is concerned, they inhibit estrogen effects, and so they are antagonists in the breast and agonist in the uterus and agonist in the bone. So these are used to treat metastatic breast cancer, and then adjunctive treatment of breast cancer. That's a typo. And they reduce the risk of invasive breast cancer in women with doctoral karma in situ, and then reduce the incidence of breast cancer in women at high risk. So you'll see these used for cancer a lot, Tamoxifen in particular. And these are all considered to be cytostatic, so they inhibit cell growth and division. Adverse effects. Notice a lot of these here. So hot flashes, so a lot of hot flashes, up to 33% of women. You can also put there vasodilation, up to 40%. So hot flashes, vasodilation are common. Nausea and vomiting is common. These next three aren't as common, but can still be problematic. Hypertension, peripheral edema, fluid retention. Vaginal bleeding is more common, up to 23%. It can be problematic. This last one, endometrial hyperplasia and cancer, go ahead and put a star there. So that's actually a boxed warning for uterine malignancy, and it can cause endometrial adenocarcinoma and uterine sarcoma that can be fatal. There's also a boxed warning for increased risk of stroke and pulmonary embolism. However, you will still be seeing these prescribed and used, so you will still see tamoxifen being prescribed because of these the benefits of getting rid of the breast cancer outweigh the risk of these box warnings, so that it is still used and they are still prescribed for breast cancer. Raloxifene is Evista, is the brand name of that, Raloxifene. And this one is a partial agonist in the bone. It does increase the risk of deep vein thrombosis and thrombolytic events. And because of that, put a star there, there is a boxed warning for increased TVT and increased PE. You guys will remember this also from the osteoporosis lectures. So it does help prevent bone loss. So You guys remember I talked about that before. And then it helps reduce the risk of invasive breast cancer. Progestins. Progesterone is the most important progestin in humans. There are newer third-generation progestins who have less androgenic effects, so these two specifically. And then this was added to the slides because this after. So after the book was published, this fourth generation came out. Drospirenone. So this is in products you guys may have seen commercials for. Yaz or Yasmin. These are those fourth generations. They thought when these first came out they were going to be a lot more safe, but these fourth generations do have increased risk of VTE. So the FDA is looking at that. So for clot, venous sorry, I accidentally stopped that. It was an accident. Thromboembolic events. Increased risk of venous thromboembolic events. Progestins. So this is where they're synthesized and secreted, and their actions. So they contribute to the development of secretory endometrium in a normal cycle and pregnancy. Put a space there. Normal cycle and pregnancy. They are used as part of contraception, and they can be used to downregulate endometrial lining, to treat endometrial hyperplasia or cancer, dysmenorrhea, etc., hirsutism, HRT, and then acne. But this is only for women that are greater than or equal to 15 years. So for the acne, they have to be older than 15 years and who have already achieved their menarche. But you can use that. And then another use that's not on here is polycystic ovary syndrome. You'll see it prescribed for that sometimes. Adverse effects. Increased risk of breast cancer. You can have bone mineral density loss, which can be problematic, especially for older women. There's a risk of osteoporosis. The risk of dementia is increased as well, which can be problematic. Weight gain, which is an adverse effect that is sometimes desired. So this may be beneficial in anorexic patients, or in other patients that have eating disorders, bulimic patients, etc. So for two reasons, it helps. So a lot of times women that are underweight will have menstrual irregularities, so it can help with their menstrual irregularities, and then it can maybe also help them stimulate their appetite and help them with weight gain. Just note on here that there is a box warning for these, and it's that if a woman is greater than or equal to 35 years and she smokes tobacco, that she's at increased risk of cardiovascular events. So here's some more box warnings. So these first two you can group together. These are for Depo-Provera, which is a medroxyprogesterone contraceptive that's injected every 3 months, and it can result in a loss of bone mineral density, and then it should be limited to situations where other birth control are inadequate. And then there's another box warning for it, which I think is kind of interesting, but that patient education, that it needs to be stated that the injected birth control does not prevent or protect against STIs, HIV, and AIDS. So in addition to that, the progesterone products have an increased risk of DVT, PE, MI versus placebo, and increased risk of invasive breast cancer, increased risk of dementia postmenopausal women, and then therefore just an overview, the estrogen and progesterone prescription should be the lowest effective dose with the shortest duration of time. So then we have the antiprogestins, the mifepristone, aka RU486, and this is the generic for a brand name Mifeprex. So this is can be used for the medical termination of an intrauterine pregnancy through day 49 of pregnancy. They may need misoprostol and possibly surgery to complete therapy. So you remember the misoprostol from before. So usually the misoprostol and the mifepristone are used in combination. Sometimes methotrexate's used too. And so this is the FDA approved use, but the off-label use is for termination of pregnancy for 63 up to 63 days of pregnancy. So it goes a little bit higher for off-label. This is one of those medications that has I mentioned Mifeprex is one brand name. It has another brand name, and it's Korlym, Korlym. And so the Korlym is mifepristone, and it is FDA approved to control hyperglycemia that is secondary to hypercortisolism and endogenous Cushing's disease, or with type 2 diabetes or glucose intolerance. So you may see it. So it's kind of like an endocrine drug. It was in the endocrine module to control hyperglycemia. But it is a pregnancy category X, which makes sense. It causes abortions, but pregnancy category X. And so if a female patient of reproductive age is going to be prescribed to control hyperglycemia, pregnancy must be ruled out before starting the medication, prevented during with contraceptives, usually 2 forms of contraceptive, and 1 month after stopping the Korlym. So, and that's usually with non-hormonal contraceptive, and maybe with hormonal contraceptives, unless there's surgical sterilization of the patient. Antiprogestins, danazol, which is the generic for the brand name Cyclamen. Mechanism of action there, I'll let you read through it, but it basically decreases secretions of SFSH and LH. So here its uses here. Read through those. Also off-label uses for autoimmune hemolytic anemia, and then idiopathic thrombocytopenic purpura, which is ITP. You'll see that sometimes being used for that. Here are some adverse effects. Androgenic effects specifically can decrease breast size. It can cause dandruff here and scaly patches, red skin. And then it also can cause amenorrhea, which isn't on here. And it's even after you discontinue it, it can still cause problems with menstruation. Contraceptives. So here now we're going to talk about preventing quote-unquote an unintended pregnancy. So that is what the medical terminology for getting pregnant, or for what contraceptives are used for, unintended pregnancies. I just thought that was interesting. Oral estrogen and progestin combinations. Okay, so these are the OCPs, oral contraceptive pills, oral contraceptive products, combination products, etc. So interesting note here, just go ahead and note these all are considered pregnancy category X. However, they are not teratogenic, nor do they cause abortion. So they're not recommended to take while you are pregnant, but a lot of women take, or not a lot of women, but you get a lot of questions, or there's women that are on it and they get pregnant and then they worry because it's a pregnancy category X. But they're not recommended to take while you're pregnant, but if you are on them, taking them, and you get pregnant, you don't have to worry about them causing birth defects or causing an abortion. And then on that same note, they're not recommended to be taken during breastfeeding because they can cause jaundice in the baby, and they can cause jaundice in the baby. And then plus 2, breastfeeding is kind of a natural form of contraception in the sense that it's harder to get pregnant when a woman's breastfeeding. So we have here the estrogen components and progestin components. Don't necessarily worry about memorizing these and memorizing all these different combinations. You'll get that when you're prescribing and stuff. But for my testing purposes, don't worry about memorizing all of these specific combinations. There are different phases. There's monophasic, biphasic, and triphasic combination tablets. Here's the triphasic here. So initially, when these bi and triphasic came out, they were advertised, or they were thought to be more to be safer and more effective. However, the WHO, the World Health Organization, has concluded that that there's no evidence that the multiphasic, so biphasic and triphasic, are safer and more effective than the monophasic, and so that's been kind of just dismissed. And so they're all equally kind of safe and effective. But you may still see where it's like, oh no, the monophasic's no longer safe or no longer effective, but that's been disproven. So, and then, yeah, and just read through these: monophasic, biphasic, and triphasic. Just read through those. There's a 24-day pill regimen, and ones with iron in it, because that are usually, the ones with iron are usually prescribed for women who have iron deficiency anemia, and that it's usually secondary to a heavy period or heavy menstruation. And then there's the extended cycle oral contraceptives, which are very popular. So these are ones like Seasonal, Seasonique. So the idea is you only have there's 4 seasons in the year, so you only have 4 periods in the year. You only have 4 4 times you kind of slough the uterine and bleed or whatever. So those are really popular. But you just basically give active tablet longer, and then you give the inactive tablet 4 times a year. So yeah. So anyways. They also have a vaginal ring. It's estrogen-progestin contraceptive, which is here. This is the generic of it, but this is Nuva Ring is the brand name of it. It's interesting in that it has less box warnings than the PO version. So you remember the laundry list of box warnings we went through with the PO, but so this one only has the box warning for being over 35, smoking tobacco, and having increased risk of cardiovascular events. So anyways, that's interesting. Common adverse effects I don't have listed on here, but it's headache, nausea, vomiting, GI upset, mood changes, and weight gain, and an upper respiratory tract infection are ones that are listed on there as common adverse effects. But so you basically insert the ring vaginally and you leave it in for 3 weeks, then you remove for 1 week, then you put a new ring in after 7 days, even if bleeding is not complete, and then you should do it approximately the same time of the day the old ring was removed. So I don't know if you guys have seen this, but this is the Nuva ring. This is the box it comes in. This is the package it's dispensed in. It's kept in the refrigerator, and then this is, it looks like a bracelet, kind of like one of those, but it's that round, and it's pliable and bendy, so you have it here. And then this is where you insert it, or the woman inserts it. So I've had women in the counseling room, whatever, tell me some think it's easy and it's no problem to insert, and others ask me and have problems inserting it. So and there's kind of more detailed instructions than just insert vaginally from the manufacturer, and you can get those from your pharmacy or whatever. But some women love it, some women hate it. Just kind of depends on the patient. There's also patch transdermal contraceptives. With these two, this is the generic ingredients here. The different brand names, but this one you apply the patch each week for 3 weeks, and then you go patch free, and you're supposed to apply the patch on the same day each week, and only 1 patch should be worn at a time, which I always think is kind of funny, but this is because people weren't taking off their patches. And then no more than 7 days patch-free interval, and that's when you have your blood flow. The FDA posted concerns of uses may increase the risk of blood clots in some women. On top of that, it also has the box warning for tobacco use, greater than 35 years, women, and increased risk of cardiovascular events. It also has a box warning for venous thrombolytic events and And then as far as adverse effects, the headache and nausea, vomiting are the most common adverse effects. Oh, and breast tenderness, the breast symptoms are also common adverse effects. Contiguous progestins. So this is for patients whom estrogen is undesirable. So that would be heavy smokers who are not willing or cannot quit using tobacco. It's for women also who have estrogen cancer. And then also for women awaiting treatment for cervical or ovarian cancer. There is also the implantation adrenogestrel, which is Implanon, which is the old that's the old brand name. It was discontinued, and then now the new one is Nexplanon, Nexplanon. But this is where you implant a rod in the inner side of the upper arm, and it's in there for 3 years from the date of insertion. And here's what it looks like. So this is where you inject it. It's this little tiny rod. This is Nexplanon. This is the new. So Implanon is no longer available. They replaced it with Nexplanon. But you'll see it. Yeah, so you'll probably see those in clinics and stuff. But it's Nexplanon. And then here's a way to usually palpate to try to figure out where it is. And if you can't, because to remove it, then you do an X-ray or you do an ultrasound. But it's a long-acting reversible contraceptive, a LARC, L-A-C. Not to be confused with a LARP, live-action role-playing. So I don't know if there's any LARPers out there in the class, but not a live-action role-playing person. IUDs, intrauterine device. So two types in the United States. There's other types available outside the United States, but just so for U.S. purposes, they have the copper is the one type, and then the hormone containing is the second type. So the copper one is just basically causes a harsh environment. It causes inflammation reaction that makes it harsh for reproduction, and it alters the endometrial and cervical mucus. Unlike the hormone containing ones, copper IUDs can be used for emergency contraceptive when inserted after up to 120 hours of unprotected intercourse. And then there's two types of hormone containing, the progesterone and levonorgestrel releasing device. But these basically work because, one, again, it's that there's something physically there, but then it's because of the hormones being released that it helps, prevent ovulation and successful reproduction. You are not supposed to leave in one system for more than 5 years, so used for less than 5 years. And then they can cause pelvic actinomycosis up to 20% of the cases, which this is a opportunistic gram-positive infection, and it's more likely to happen the longer you keep it in. So here's some IUDs from around the world and from back in time, and so depending on where you're at, where you're practicing, you may see some of these other ones, but I thought this was an interesting photo. It's almost like an eagle. I don't know. It's just interesting. This is from Up to Date. I didn't make this up. This isn't some crazy thing that I found on the dark web. It's from Up to Date, guys. But I thought this was interesting. So the progestin contraceptive mechanisms, we already kind of talked about this a little bit, but it thickens the cervical mucus, inhibits ovulation, inhibition of implantation, but it's not effective once the implantation process has occurred. So these cannot be used for emergency contraceptive, unlike the copper IUDs. They are contraindicated in women or patients that have multiple sex partners, and if they're in place with STIs, there's an increased risk of PID, pelvic inflammatory disease. So the mechanism of action for hormonal contraceptives. They basically just block proper ovulation, is what it is. And then the progesterone only, so those are the combinations. They affect ovarian function and the cervical mucus. and just make it inhospitable for conception. So they are used for contraception, what we've kind of been talking about, endometriosis, treatment of dysfunctional uterine bleeding, treatment of acne, and emergency contraception. So it's usually those are at higher doses. So this is like your plan B. Adverse effects, we've seen some of these before, but just to review, so VTE, venous thrombotic disease, MI, cerebral vascular disease, jaundice with intrahepatic cholestasis, hepatic adenomas, increased incidence of migraine headache, breakthrough ovulation with pregnancy, mood changes, and then these effects on the lipids, which these can actually be beneficial effects. So you'll notice they're decreasing LDL, increasing HDL. There are some beneficial effects that have been shown with low-dose oral contraceptives. So lower risk of these types of cancers: ovarian cyst, ovarian cancer, and endometrial cancer, and benign breast disease. Lower incidence of ectopic pregnancy, iron deficiency, and RA. And then it helps ameliorate some of these dysmenorrhea, endometriosis, and these premenstrual symptoms. So here's a summary table: drugs, clinical applications, adverse effects, contraindications, continued. Now we're going to androgens and the androgen inhibitors. So we're going right here to these. So these are stimulated by LH. Just kind of overview. Don't worry, I'm not going to pull test questions from here. Sites of production: the testes, ovaries. First, testes for males, ovaries and adrenal cortex for females. Here's the male axis, just for review. More just FYI, don't worry about it. Androgens. So testosterone is the most important androgen in humans. It helps with a lot of things, stimulates libido, both males and females. Accounts for the majority of changes that occur at males at puberty, and it has anabolic activity. So it's used in replacement therapy in hypogonadism and hypopituitarism. So you got your low T, bro. So for if you have a low T, low testosterone, hypogonadism, acceleration of growth in childhood, and then anabolic agent, especially in debilitating diseases such as AIDS or other wasting syndromes, breast cancer, geriatric patients. Adverse effects, so it can masculize women, so make them more man-like, masculization. Azoospermia, which is just basically defective, kind of messed up sperm that's not formed properly. Decreased testicular size. There is abuse potential, so put a star by there, and there is a box warning about it. So abuse potential, because I mentioned too, athletes will, to help them improve their athletic performance. So they help stimulate muscle growth, and so some athletes misuse these. And because of that, the FDA issued in October 2016 a testosterone safety alert, special alert. So it's a class-wide labeling changes for all prescription testosterone products. A new warning will alert prescribers to the abuse potential of testosterone and potential for serious adverse effects, especially those related to heart and mental health. In addition, the abuse and dependence and warnings and precaution section have been revised, blah, blah, blah. So you can read through that. But this is a new warning as of October 2016 from the FDA. And it is something to think about, and if you're going to be prescribing it. Because testosterone is a controlled substance, but it's not a C2. So as PAs, you guys will be able to prescribe this, and you will be getting requests from this. And there's some real uses for it, so it's not... it's just the abuse potential's there, and you guys have to be mindful of that. Like with some other drugs you guys can prescribe, just be mindful of the abuse potentials. I thought this was interesting too. You can advise healthcare providers the importance of measuring serum testosterone concentration if abuse is suspected. So that's something to be mindful of and think of when you're prescribing these. So here is a summary table that I like, testosterone replacement therapy preparations. So this is more for your knowledge than for testing purposes. So I'm not going to pull specific questions from the dosages, for example, typical dosing ranges, nor the application site. But I do like this column here, so put a star by there. I want you guys to read through that and see the disadvantages and toxicities. And the reason is because this is all testosterone, but this is IM, injectable versus patch versus gels, pumps versus PO versus pellets versus buccal testosterone. I do want you guys to look at these and kind of know the differences. And I'm going to talk about them a little bit here. But so intramuscular are cheaper, and they are usually preferred by insurance companies, but people don't like them as much. I mean, a lot of people don't like injections, but some of the reasons they don't like it is because of the fluctuations in serum testosterone levels, and so they just don't get that as good of testosterone levels with the intramuscular. The transdermal patches can be kind of popular, but it just kind of depends on the patient specifically. And then skin rash, poor adherence is just one of the things that the patches come off. You have to be careful when you're showering, etc. So that's something that you think about. The gels, pumps, and solutions are very popular. These are definitely most popular, most requested things you probably will get asked to prescribe. One disadvantage is that they are more expensive. So in insurance companies, maybe not prescribe it. But as far as what patients prefer, they usually prefer the gel pump solution. They usually prefer this topical. They kind of rub in. Unlike a patch, you don't have to worry about it showing, or that you have to worry about it falling off or covering up, etc. But one disadvantage is the normal serum testosterone level is not achieved in all males, the hypogonadal males. So that's something to think about, but it is very popular, and people like this. And so usually practitioners start with the transdermal gels. The PO is there, but they have the GI adverse effects people don't like, so you can't do PO. And they have the implants, which I haven't seen are super popular. It's just going to kind of depend, but there is the optimal dosing, and that's as far as achieving certain testosterone levels and stuff, it is still kind of the jury's out on that. And then the buccal testosterone people don't like, very poor adherence because they cause a lot of mouth. Those are the ones you stick in your your buccal cavity. But then those people don't like because of the mouth irritation, gum irritation, taste abnormalities, etc. So as far as patients go, they prefer these. These are the ones that usually the guidelines will kind of point to starting with these if you can, if the insurance will pay for it, if the person has money to pay for it. If not, then they typically will go to the IM, so injectable after gel, and that'll just kind of depend. But so pay attention to the disadvantages of toxicity. Look at those and think about those, because depending on where you practice, I mean, you may never prescribe this, but I bet you guys will come across this and practice it. So they're really popular. You guys have seen all the advertisements, etc., but about low T, so I get a lot of prescriptions for testosterone preparations. Some compounding pharmacies that I've worked at, we would make testosterone. So for male and women, just again, most people like the cream gel, you just put it on. But so we would, there are compounding pharmacies that'll make these up for you guys, and then again, popular for patients, etc. So then we're going to some few other androgen suppression and anti-androgen. First, we have the GnRH analogs. So we have the leuprolide and the goserelin. These both produce gonadal suppression, and they are used for palliative treatment of advanced prostate cancer, help manage endometriosis. They can help treat anemia, help with central precocious puberty, and then the downregulating of ovaries prior to ovarian stimulation, and infertility treatment. 5-alpha reductase inhibitors, we talked about these a little bit during the BPH, but this is the finasteride and dutasteride. These inhibit, it's 5-alpha reductase inhibitor, inhibit androgen metabolism enzyme 5-alpha reductase, and thus inhibiting the formation of DHT, which is an androgen necessary for prostate growth and function. So therefore, we talked about them, like I said, in the BPH lecture, so they are used for BPH. And then finasteride has approval for male pattern baldness. Adverse effects, though, they put a star by here, teratogenic properties. So, and it's so serious that pregnant women are cautioned about working with these medications because breathing the dust could result in teratogenic effects. This is pregnancy category X. And then they can cause impotence and decreased libido. So definitely two common adverse effects I get asked a lot at the pharmacy about from the gentlemen that are taking these. Then we have receptor antagonist, flutamide, bicalutamide, and nilutamide. Uses. So these help treat metastatic prostate cancer, and usually it's in combination with other GnRH agonist analogs. And last but not least, we have the ketoconazole, which you guys remember from anti-infection lecture. It's an antifungal medication, but it actually helps decrease testosterone synthesis in males. So there is some experimental use in prostate cancer, so it has an off-label use of helping with advanced prostate cancer. And here we go. Here's a summary, last but not least, but it has the adverse effects and contraindications. So you'll notice here the pregnancies listed on both of those. Let me see. Yeah, pregnancy. Yeah, okay, good. It's listed. I was making sure that it was listed here, but it's listed here for the 5-alpha reductase inhibitors. But you'll notice it's here too for these and these.